So we had a conversation earlier about the new process, and then we were talking about on the off time about where we put patients, right?
Yeah.
So and you brought up a very good point, because that day we did that, they were still working on the communication part.
Right.
And one of the things that I like as a provider is I like to take care of patients. One of the things I don't like is thinking about the logistics of the department. I like to order stuff, and then I like it magically to happen. But obviously, there's the back end.
Yeah.
So you brought up a very good point, because there was a hiccup on the communication side. And where I want the providers to be is we think about what we're going to order, and then the folks doing the orders complete the task, right?
Yeah.
And so that, I like my triage nurse to focus on triage, and I like my charge nurse to focus on the resources and where the patient goes in the department. But that was a great point that you brought up. So I wanted to talk a little bit about low acuity, and this just kind of goes to how I think about low acuity patients, and to get your thoughts on this. So, because a good portion of them we see are going to be low acuity patients, and one of the things that I think is you can put this model in place and you can contact a patient early, right?
Right.
And I personally believe anything that stands in between you and a patient is non-value added, because you are the value of seeing the patient and your clinical opinion, your professional opinion. But let's say that you have somebody that comes in with a cold, and I'll pick someone that's 30 years old, heart rate's 120, they look otherwise pretty good. What you want to do?
So, depending on the patient and their medical history,
They're healthy. They're healthy. Their BMI is 35.
I might get a flu, a COVID, RSV, and a chest X-ray if it's warranted.
Which is beautiful. I was hoping you would say that, because and this is, my wife says this, that everybody makes spaghetti, and everybody does it their own way, and everybody believes it's their best. It doesn't mean that one spaghetti is better than another. It's just a different way of doing it.
Right.
So when I think about patients, I literally categorize them. The patient I'm discussing, a little tachycardic, right? But they look good,
Right.
and they're not old, so probably going to be a discharge, right?
Yes.
So if you're comfortable, and if you say, hey, I'm worried about something bad, then you're ordering sepsis stuff, and they're going in a different pathway. But we're going to take the pathway of, let's just say, instead of the heart rate of 120 is 80, right? They look okay, but
lungs are clear on physical exam.
Yeah. So you're worried they get the flu or
Right.
bronchitis or whatever. So let me ask you this: on your testing, are you testing because you want to know, or you think the patient wants to know?
It depends on the patient. If I feel like they have any risk factors, and
But you don't. You think this one's a pretty straightforward flu cold.
I would say historically, it depends on the culture of the facility that I'm in.
Okay, which is a great answer. So the way I look at it, and again, I'm not telling you how to practice.
Mm-hmm.
It goes back to spaghetti.
Yeah.
Is I try to think of, if I'm going to discharge a patient, then what do I need? And what I'm hearing from you is, as a clinician, you really don't care what the flu test is or the COVID, because it's not going to change what you do.
Mm.
I mean, it's information, but it's not like information you're going to necessarily act on, unless you're going to do Tamiflu and Paxlovid, which we can talk about separately. But other than that, you're ordering. So the reason I brought this up is I had one of the practitioners I was talking to, and they came in for knee pain, post-op knee pain.
Okay.
And the knee looked great. And they said, well, I said, what'd you order? And they said, well, I got an X-ray of the knee. And I said, okay, is it broken? No, I don't think it's broken. So why'd you get the X-ray? And a lot of people do that, right? It's like a knee-jerk reflex.
Yes.
And they said, well, they expect it. And I said, well, did you ask them? And they said, well, no, but I assumed they wanted it. And then I said, what else? And they said, well, I got blood work. And I said, okay, why'd you get blood work? And they said, well, to make sure there's not an infection. And I said, well, you looked at the knee. Was there an infection? They said, no, definitely not an infection. I said, so what blood work would tell you if there's an infection?
Right.
And because I'm giving you a hard time today, what blood work would tell you there's an infection or not an infection?
So are they having an elevated white count?
So what's the number?
Yeah. What's the number?
Yeah, so you're right. Let's say it's 15,000.
12.
So it is a great question, and it's actually a literature-based question.
Yeah.
So the number that predicts a bacterial infection, what we're concerned about, is 30,000.
Okay.
So a lot of people don't know that.
Right.
And bands are loosely associated with it.
Right.
So now you and I both know sometimes we'll order a test, and when we talk to the hospitalist, we'll be like, it's 15,000, that's high.
Yeah, it's
right?
elevated. Yeah.
Right. But if you look at it from a literature base, there's no proof that that does anything. In fact,
Right.
there was a great study that was done on kids with proven bacterial meningitis, and they broke them into 3 categories: low white count, normal white count, high white count. Which
Right.
one of those was most predictive of meningitis, bacterial meningitis?
So if they're having a high white count, is it
It was actually normal.
okay?
The next most common was low, and the least common was high.
Okay.
So it really comes down to your clinical gestalt.
Right.
So with that provider, I asked that, and they said, well, I ordered stuff because then the patients in the back, I have more time, and I can get to them when stuff starts coming back.
Right.
But really, it was the presumption that that's what the patient would want. So
Yes.
when I see somebody, I break them into those categories of, if I'm going to discharge, so if I was seeing you, and I would say, hey man, look, I think you got the cold, or you got the flu, you got the crud,
Yeah.
and I can do whatever voodoo medicine. I can give you a dose of steroids or a puffer or whatever, you know what I mean? But it's just going to take some time to get better. And you say to me, okay, well that's fine. I want a note for work, and I want to go home and take 12 days. Great. Or you could say to me, hey, I want a flu test because my grandma's 97 years old, and I'm worried I have the flu, and I want to give it to her. I'd say, okay, that's fine. But I tell you not to be around your grandma anyways, because even if it's not the flu, you get the crud. So, but it's interesting, when you have those dialogues, a lot of times people don't want what we presume they want. So the lady with the knee wanted pain medicine. That was their thing.
Right.
When you asked her, what do you want? Do you want the x-ray? Do you want the blood work? They were like, no, I don't want to be stuck. It's not broken.
Right.
I just want something additional for pain. And it was just an interesting kind of
Yeah.
conversation.
Little discovery there.
But I'm going to give you a hard time. I'm going to ask you another question.
Yeah.
Because I love asking these questions.
Yeah.
Is why do we get a strep test? Do you like doing strep tests?
Why do we get them?
Yeah.
To make sure that it doesn't go untreated and.
Okay. So let's say that you got strep. I don't diagnose it. What's going to happen to you?
Most likely nothing.
Okay. So what the concern that most people worry about is rheumatic heart disease, right?
Right.
And what's the frequency of that?
Well, that's what I'm saying. It's very minuscule.
Yeah, it's less than 1 in 3 million.
Right.
So the question comes down to, because the federal government recommends that we get a strep test, right?
Right.
But it's interesting, they want a strep test, but they don't care about strep result. All you gotta do is get the test.
Right.
So when you look at this, and I know I'm giving you a hard time, but that's what I'm supposed to do,
Of course.
is the reason I treat sore throat is for peritonsillar abscesses. It's a very reasonable question of what's the frequency of that. It's about 1 in 900. Does it make a difference if it's bacterial or viral? Not really.
Right.
So when I see a nasty throat, I tend to put them on a short course of antibiotics for that. What's the risk of anaphylaxis? So you give them an antibiotic. I know I'm hitting you with all kinds of hard questions. It's about 1 in 20,000.
Okay.
So when you do ER, what we do is risk stratify, right? And we're judging and how much risk does this patient and that patient have.
Yeah.
So what's the optimal duration of treatment for strep?
Probably 7 to 10 days.
Which is a great question, because that's what most people say. And there's no literature that says that. In fact, the original studies that looked at strep and why we have treated all these years occurred in Wyoming in 1962.
Okay.
And military recruits. And they took 2 separate groups of military recruits, gave them strep, and they did bad. Since 1962, they have not been able to replicate those studies. And the idea is that the original inoculation they gave them was with a particular virulent group of strep. And so those poor guys suffered out of that, but it has changed our whole practice. So me personally, I treat strep for 3 days.
Okay.
And the reason I picked that number is if you're not better in 3 days, you should come back and see me. If I give you 7 days or 10 days, then you may say, well, I just haven't given it enough time. But there's literature that says that you as a healthy guy, you get pneumonia, I give you a single dose of antibiotics because they're so broad spectrum, a single dose is enough to get rid of your pneumonia in a healthy person. It's kind of changes how you think about it, doesn't it?
It does, yeah.
I'm going to give you another hard time.
Okay, yeah.
All right. I hope you don't mind.
No, you're fine.
So somebody comes in and it hurts to pee.
Okay.
And what do you want to do? Now, you know my trick by now.
You know, you've got dysuria. Is it a male or a female?
Let's say it's a dude.
Okay. So you're going to get a urine.
Okay. So your urine comes back and it shows 2 white cells and no red cells. What you going to do?
just give them some antibiotics. And
So I agree with you. I would do the same thing because the predictive value of the symptoms is greater than the test.
Right.
So why'd you get the test?
Because it's just common practice.
Right, which is
Yeah.
perfect, right? But
Yeah.
that's what we do a lot of that without, because if I had asked you and I said, hey, you got dysuria, and a guy, it's a little bit different, right? Because
Right.
you got to think about STDs and all that kind of stuff. But I would have a conversation with you about that and then see if you wanted the urine. Now, if you want a urine culture, that's reasonable.
Right.
But the urine test doesn't really tell me a whole heck of a lot, right? Because you would
Right.
treat it anyways, which is the right thing to do because you're treating based on the symptoms.
Right.
I'm trying to think of some other ones to give you some hard time.
No, you're good.
10-minute mark.
Okay.
I'll just restart.